Well, this is a interesting diabetic case, an advanced diabetic case. The patient was pre-treated with Eylea 4 weeks before surgery, and a little bit laser has been performed too, maybe 200, 300 effects. I perform 27 gauge vitrectomy using an EVA machine, and of course a chandelier light. The first step is the peripheral vitreous rhexis, which means an opening of the posterior hyaloid in the periphery. So you see that the cutter is moving in the periphery and opening the posterior hyaloid. The central retina at the posterior pole is detached shallowly, a shallow detachment, but it is detached. So this is a chronic and old detachment. I think you see quite nicely here the opening of the posterior rhexis, posterior hyaloid, and now on the other side I'm trying to open here the posterior hyaloid. This maneuver functions usually in the most part of the eye, but there is sometimes one quadrant, often the nasal quadrant, where the posterior hyaloid is completely attached. So this maneuver is not possible to perform 360 degrees in all cases. So this is a peripheral vitrectomy with scleral impression. I always work with chandelier lights in these cases. I think this is an important point to success. There's only a slight cataract, so I'm performing a lens sparing vitrectomy. The patient is in the 40s. I stay now with membrane dual, simply to recognize the structures better. And now you see that this that the posterior hyaloid at the central pole is firmly attached to the retina in a U shape. So this has to be removed. So the removal of the posterior hyaloid is the aim of diabetic surgery. So this bunch of attached posterior hyaloid in a U shape has to be removed in order to release the traction on the retina, so that the retina can reattach. The retina shows a shallow detachment at the posterior pole. Okay, now I'm switching to a bimanual removal of the central posterior hyaloid. In the right hand I have a intravitreal forceps. I think it's an ultra peel forceps from Dork, and in the left hand a 27 gauge vitreous cutter. which I think is a game changer in diabetic surgery. Why? Because the 27 gauge cutter is very small, and you can delaminate and dissect posterior hyaloid. This is not possible with a 23 gauge cutter because it is simply too big. Here you see this is posterior hyaloid, which is attached, and this is the plane I was looking for. The problem, of course, of this membrane peeling, or to be more precise, removal of posterior hyaloid, is that it is attached to the large vessels, the temporal arcade, so you always run into danger to injure the large vessels, and this should be avoided, of course. You see, all this tissue from the over the optic disc to the edge of the membrane, all this is posterior hyaloid. Now, you see this tissue, this is posterior hyaloid. So this has to be removed because this U-shaped membrane complex causes the central tractive detachment. So you see all this is posterior hyaloid tissue. So what I'm doing now, I'm elevating the hyaloid with the forceps and cutting it with the cutter. It is important to destroy the bridges between the big membrane complexes so that the tractional elements are destroyed. Well, now I'm using a vacuum cleaner. I have to fixate the trocar to insert it. Otherwise it will bend inside the trocar cannula. And the vacuum cleaner is a good instrument for delamination of these membranes. If you have 25 gauge, I would prefer the Knop spatula from iTech UK. So here you see this is a good opening of the posterior hyaloid. And here the tissue is really firmly attached. So I find no way to come inside here. Now I'm working with the forceps in the right hand side and with the scissors in the right hand side and the forceps in the left hand side, This is a 27 gauge forceps. So I'm cutting now the bridge at this point. And cutting bridges results in reduced traction. Of course, the main question in this thick membrane is it possible to make a complete removal without injuring the large vessels? And so the answer is remove as much as possible, and especially cut the bridges so that the tractional elements are removed. So these kind of surgeries require, of course, time and patience. The surgical time for this surgery was 1 hour and 10 minutes. Now you see this bridge is clearly open. The posterior hyaloid is removed at this place. So this is a good success. And I'm working in the left hand with the ultra peel forceps, in the right hand with a 27 gauge curved scissors from Dork. For these surgeries you need a forceps, a scissors, and one delaminating instrument like vacuum cleaner or knop spatula. Now I'm trying to open this bridge here, but it's hard to come in from the peripheral side, so I'm trying to open from the central side. And I'm working again with the vitreous cutter, 27 gauge, which I really think is a time changer for diabetic surgery. So even if I would use 25 gauge trocar cannulas, I would prefer to have a 27 gauge vitreous cutter. Now I'm cutting a bridge into this posterior hyaloid. This white line below the instruments is a subretinal strand, which is a symptom of the long-standing shallow detachment. You see actually that there is a strand around the optic disc, on both sides of the optic disc, also almost across the macula. I will not remove these strands because I doubt that they contribute to the detachments. I'm again trying to cut openings into these bridges. You see, here is actually a retinal fold which I'm opening now. This is very important. I'm opening a retinal fold at the superior arcade. Here's one more bridge which I'm destroying now. You see now with the cutter. and I again can destroy the connection between two membrane complexes, which again results in a reduction of tractional elements. So the aim is to remove the complete posterior hyaloid, destroy the bridges between the membrane complexes, and trim the membranes as much as possible. I injected Eylea 1 month before surgery to reduce or minimize intraoperative bleeding. I think this is a very important part of successful diabetic surgery. Because intraoperative bleeding makes surgery difficult, and postoperative blood is a risk factor for PVR. So I would really like to open this membrane here in order to destroy the connection between these two membrane complexes. But as you can see, it is not easy. This is some blood. So I think you can see, dear colleagues, that a bimanual approach is really important. A monomanual approach is difficult to remove these thick and firmly attached membranes. So this is again a forceps in the right hand, a scissors in the right hand and a forceps in the left hand. I'm trying to find my way under this bridge, which is quite difficult, but it's important to take your time in order to avoid retinal ruptures. So this is now the important bridge which I want to cut. Now it is cut. So now I have destroyed the connection between these two membrane complexes. You see now I have the the plane between the posterior hyaloid and the retina. So I will of course try to continue here and remove more posterior hyaloid. It is very important to have time for the surgery. If you are in time constraints, you will have difficulties performing the surgery. You see again here the retinal fold. So it's important to remove more tissue in this area so that the retinal fold can open. So the scissor is cutting the posterior hyaloid tissue and the forceps is elevating the posterior hyaloid. Here you see again the black fold. Here, this is the black fold with the vessels inside. So I'm trying to continue here to open more, to remove more membrane tissue. The light I'm using is a xenon light from Synergetics. It's called AWH, which is AWH. That's the name of the light. It's a 25 gauge light from Synergetics, and the light source is either the vitrectomy machine or a xenon light source from Synergetics. So here you clearly see that the bridge has been destroyed. So we can hope that we'll have some release of tractional elements in this area. The tissue is very firmly attached here. But I'm quite happy now because the important bridges are removed and destroyed. So I think that the tractional part is removed. Now comes an extensive laser coagulation. There's been some scatter laser before. I always laser with scleral impression in order to reach the ora serrata. I usually laser about 1400 laser effects. So now I'm doing some more trimming of the residual membranes, and again this is quite easy with the 27 gauge cutter, but I would not use for this job a 23 gauge cutter, at least not in my hands, but I feel very safe with the 27 gauge cutter. And here's again more posterior hyaloid. And these white structures again are subretinal strands. This are subretinal strands. So I'm now removing the final part of this posterior hyaloid. I think you see very nicely here how well this small cutter can remove this part of the posterior hyaloid. I think I should use the forceps, but I'm confident without a forceps elevating the structure. I think it is opened now. The two membranes are separated. You see they're separated. So the tractional element is removed in this area. Okay, so the final steps are a fluid air exchange, injection of 0.2 milliliter Avastin, and then only a air tamponade. Thank you very much.